Hi, everyone, and welcome. My name is Dr. Gregory Gordon, and I'm the Chief Medical Officer of the Scleroderma Research Foundation. I'm honored to have you join us today for our educational webinar, Scleroderma and the Lungs, a Spotlight on ILD. At the SRF, we are committed to sharing knowledge that empowers people living with scleroderma. Today's program will focus on interstitial lung disease, or ILD, one of the most common and serious complications of the disease. We'll explore the connection between scleroderma and ILD, how screening and diagnosis are approached, the treatments available today, and what potential future therapies might look like. We'll also discuss strategies for managing symptoms and improving quality of life. Before we get started, I wanted to note there will be a Q&A session after the presentation. Please feel free to type in your questions in the Q&A box on your screen, and we'll get to as many of them as possible at the end of this session. With that, I'm delighted to introduce today's speaker, Dr. Toby Maher. Dr. Maher is a professor of clinical medicine and director of the Interstitial Lung Disease program at the Keck School of Medicine at USC. He has spent more than 20 years specializing in pulmonary fibrosis and interstitial lung disease, leading research, clinical trials, and care for patients from around the world. He has authored over 400 publications. He serves on the editorial boards of leading respiratory journals, and he is a co-principal investigator of the Conquest clinical study. Please join me in welcoming him today.
Thank you very much, Greg. Good morning, good afternoon, everybody. It's a pleasure to be here to be talking about scleroderma-associated ILD, and I'm very grateful to the Scleroderma Research Foundation for providing this opportunity. As Greg said, there will hopefully be lots of opportunity for questions at the end, so if anything comes up that I've not made clear, please feel free to ask. So if I can make my slides advance, there we go. Those are my disclosures. So as Greg has said, there's a few things I want to try and achieve in this talk. One is to explain what interstitial lung disease is, then to explain why it's so important in scleroderma, to talk through how we diagnose and identify it, how we treat it, and then I'm giving over the last 5 minutes of the talk to talk about clinical trials and how they are relevant for people living with scleroderma and scleroderma-associated ILD. So first off, to start with the lungs, our lungs are there to facilitate gas exchange, which is to say that their job is to get oxygen into the body so that that can be used as a fuel by the cells in our body, to get out the waste gas, carbon dioxide. People might remember from high school the way our lungs look. We have the trachea, which is our windpipe. That divides into right and left, and then it keeps dividing and dividing into ever smaller tubes until we get right down to the end where we have the little air sacs, or the alveoli. And it's in those little air sacs that the oxygen gets from the lungs into the bloodstream. So they're the very important part of the lung. On the left-hand side of my slide, we've got a picture of normal, healthy lung tissue. And each of these little walls that looks a little bit like a hexagon is an alveolus that has been cut in cross-section. And what you can appreciate from this slide is how thin the wall of the alveoli are. They're lined on one side by epithelium, which is the same thing that we find on our skin or in the inside of our mouth. And on the other side, they have a little blood vessel that is lined by so-called endothelial cells. Between those two cells is a tiny, tiny space called the interstitium of the lung. And in healthy lungs, that interstitial space is a fraction of the width of a hair, and it has nothing in it. It's just there to allow the oxygen to pass in one direction and the carbon dioxide to pass in the other. And at the bottom on the right here, we have a cartoon of a single alveolus So on the inside, these blue cells are the epithelium. On the other side, we have the capillary with the blood cells in it that pick up the oxygen. And then the little white gap in between is the interstitial space. And so when we talk about interstitial lung disease, we're talking about any condition that can cause either inflammation or scarring in that space between the epithelium and the capillary. Any inflammation or fibrosis within the interstitial space will cause breathlessness initially on exertion, but as it gets more severe, it can ultimately cause respiratory failure such that people need oxygen either on exertion or if things are particularly bad, they will need it at rest as well. And in my clinical practice as a pulmonologist, I see lots of different causes of interstitial lung disease. If you go to medical textbooks, there are more than 200 different conditions listed that can cause interstitial lung disease. One of the commonest that I see in my practice is something called idiopathic pulmonary fibrosis, which is scarring of the lungs of unknown etiology, which is in general related with aging. But there are other conditions such as hypersensitivity pneumonitis, which is also known as bird fancier's lung, which is a reaction to things that are breathed in. We know that certain drugs, particularly drugs used to treat cancer, can cause interstitial lung disease. And we also know that certain industrial exposures, such as asbestos or coal or silica, can also cause interstitial lung disease. But about 20 to 30% of the people that I see in my clinic will have autoimmune disease-related interstitial lung disease. So we know that autoimmune diseases, which include scleroderma, but also other conditions like rheumatoid arthritis and myositis, can, as part of the condition, affect the lung. And obviously, I'm now going to go on and discuss that in the context of scleroderma. So certainly, I'm sure nobody on this call needs me to explain what scleroderma is, except to say that it is a systemic autoimmune condition that can affect multiple organs in the body. Classically, it tends to affect the skin, and people with the condition will have Raynaud's phenomenon. But about 2/3 of people will also have lung involvement. And on the right-hand side of this slide, you can see a CT scan of someone's lungs. There's a follow-on slide from about 4 years later, and you can perhaps appreciate that the gray shadowing has changed, and that is evidence of the development of interstitial lung disease. And one way of thinking of the interstitial lung disease in scleroderma is that it is very similar to what happens to the skin. As everyone knows from personal experience, skin in scleroderma will tend to become thicker and stiffer and less flexible. And in general, that is what is happening with the alveoli in the lungs of individuals who develop interstitial lung disease. So on the left-hand side, we have the picture that I've already shown you of normal healthy lung tissue. On the right-hand side, we have a sample of lung tissue from someone who had scleroderma-associated ILD. And what you can perhaps appreciate is that on this scleroderma lung biopsy, we can still see the alveoli, these little hexagon-like shapes, but rather than having the nice thin walls as we see in the healthy lung, instead, those walls have become thickened with fibrous tissue. And as we've already discussed, that thickening means the oxygen has to travel further to get into the bloodstream, and that consequently will cause breathlessness for people with scleroderma-associated ILD. And scleroderma ILD has gradually become more important for people with scleroderma. And the reason is that over the last 40 years, we've got a lot better at treating many of the problems that are associated with scleroderma. This is an old study that was published 25 years ago, but it makes an important point. So 50 years ago, people with scleroderma most commonly died from kidney problems and kidney complications. But we got a lot better at recognizing the importance of managing kidney disease. And it's now very rare for someone with scleroderma to have serious kidney problems because we proactively seek to prevent those. As kidney problems became less common, something called pulmonary hypertension, which is high blood pressure in the lungs, became more of an important problem. And then in the late 1990s, we began to develop effective treatments for that. And so we've got much better at treating pulmonary hypertension. And consequently, whilst it is still a problem for people with scleroderma, it doesn't tend to be the life-threatening problem that it was 25, 30 years ago. As we've got better at managing these things, the relative importance of scleroderma ILD has increased and increased. And if we fast forward this study another 20 years, I think the importance of ILD would have been seen to rise even further. And thankfully, as I'll talk to you over the course of this talk, in the last few years, we've begun to see the development of effective treatments for the interstitial lung disease associated with scleroderma. And so I think finally we're beginning to get on top of that as a problem. Why is ILD an important complication? Well, as everybody living with scleroderma knows, it is a disease that has an important impact both on people's quality of life, but also potentially their life expectancy. And we know that for people with ILD, the impact of the disease is even greater. And the risk to their life expectancy is even bigger. So I think it's very important that we identify ILD and that we treat it early so that we can hopefully prevent it developing into a life-threatening problem for people living with scleroderma. So when is it that we should suspect that someone has ILD associated with their scleroderma? Well, there's about a 60 to 70% chance that anyone with scleroderma has interstitial lung disease, but there are certain clues that this may be more likely. So if people have respiratory symptoms, if they have breathlessness on exertion, if they have cough, that makes it more likely that they have ILD. Smoking history is important. If people have smoked or are active smokers, it is more likely that they'll have interstitial lung disease. There is a relationship with ethnicity and also with gender. So interestingly, although scleroderma is rarer in men, when men get scleroderma, they are more likely to develop interstitial lung disease. Similarly, people with diffuse cutaneous disease as opposed to more limited skin disease are also more likely to develop ILD. And then we can also use the autoantibodies, the things that we measure on blood testing, to see if people are more at risk. So people have anti-S70 or anti-topoisomerase antibodies, they're more likely to develop ILD. And by contrast, people with anti-centromere antibodies are less likely to. So how should we identify interstitial lung disease? Well, there are two main tests that get done, one which is important for diagnosing ILD, the other which is important for monitoring it. So the two main tests that we use are CT scanning. So that's undertaking imaging of the lungs. And the CT scan is really the gold standard way of diagnosing interstitial lung disease. By allowing us to see the lung tissue in detail, we can identify whether people do have interstitial lung disease or not. And the CT scan is a very good way of doing that. Often people raise concerns about radiation exposure. And it is true that there is radiation involved in CT scanning. If you have a CT scan, it's equivalent to about 2 years of background radiation. So just by living on this earth, we are constantly exposed to radiation. By having a CT scan, you're essentially getting the amount of radiation you would get over the course of 2 years of just normal activities. Often in itself, that doesn't cause great problems, but obviously we do try and avoid doing multiple CT scans unless there's very good clinical reason to do so, because obviously there is a cumulative exposure over time if you have multiple CTs. But given the risk posed by interstitial lung disease, we think it important that patients newly diagnosed with scleroderma should have a CT scan to assess the possibility that they have or don't have interstitial lung disease. And then the other test that we tend to do is pulmonary function testing or lung function testing. And this is a series of tests where we get patients to blow in and out of different machines. And that allows us to know about the sort of the size and the stretchability of the lungs. It allows us to learn about the caliber of the tubes in the lungs. And it also allows us to measure how well the lungs work at getting oxygen from the air into the bloodstream. And those values can be really useful in helping us assess how severely someone is affected by interstitial lung disease, but also it allows us to measure how the condition changes over time. So it allows us to measure the effectiveness of treatment. Lung function testing is very safe, although people often find it slightly unpleasant to do because it requires quite a lot of effort to do the blowing in and out. But it does provide us with a lot of valuable information when it comes to monitoring the condition. So in essence, how do we diagnose and assess the severity of the interstitial lung disease? Well, the CT is really about the diagnosis, and the lung function is about measuring the severity. One of the other things we can also do is just measure people's oxygen levels when they're walking around. That in more advanced disease also gives us some measure of severity. And in some centers, they'll also ask you to fill out questionnaires to try and measure the effect of your symptoms on your quality of life. And so these are representative examples of CT scans. So healthy lung tissue looks like this area here, with the white dots being blood vessels and the lung being black in color. The interstitial lung disease is the sort of gray shadowing that you can see at the back here. This is mild early disease. The bottom right-hand corner is someone with more advanced disease, where you can begin to see destruction of the lung tissue itself. There are a number of the medical societies that have released guidelines on how we should identify and then monitor for interstitial lung disease. This is from the American College of Rheumatology. But in general, as I've said, the measures that we can use for assessing severity, we can then use at each clinic visit to monitor progression. The CT scan can be used to monitor progression, but because of the radiation exposure, we tend to avoid doing that. But the lung function tests are a safe and excellent way of really measuring change over time. So having thought about the diagnosis, what possible treatments can we use? Well, there are a lot of potential therapies for patients with scleroderma, and a number of these have been tested in clinical trials in patients with interstitial lung disease, and I'll just talk about them all briefly. So it's worth saying that steroids are something that we increasingly tend to avoid. So steroids such as prednisone or methylprednisone or hydrocortisone are immunosuppressant drugs. They are widely used for treating conditions like asthma, and they do have a strong anti-inflammatory effect. But actually, in scleroderma, we worry that these drugs can cause problems with the kidneys. So higher doses of steroids can trigger episodes of high blood pressure. And so particular caution should be taken for people with scleroderma about using steroids, particularly at high doses. We also worry that long-term use of steroids can cause side effects like thinning of the bones and cataracts and high blood pressure. So in general, we try and avoid the use of steroids wherever we can. The first treatment that we used for treating interstitial lung disease specifically was a drug called cyclophosphamide. This is a very broad-acting immunosuppressant drug. It can either be given in tablet form or it can be given by monthly injections. There was a clinical trial done with cyclophosphamide over 20 years ago now. This was called the Scleroderma Lung Study and subsequently was called SLS-1. What it showed was that cyclophosphamide, when you're giving it, is actually quite effective at improving lung function. The problem is that that cyclophosphamide tends to cause a lot of side effects. So it can cause nausea, vomiting. It can also cause bleeding from the bladder, and it also increases the risk of developing bladder cancer over the longer term. So although it's a drug that we used effectively, and this is just an example of a patient I had with interstitial lung disease, if I just fast forward, this is after treatment, and you can appreciate that there was a clear change with cyclophosphamide. So although this was a drug that we used for quite a long time because it could be effective, it is something that we don't tend to use nowadays because we have much safer and better tolerated alternatives. The second drug that was studied was mycophenolate mofetil, or MMF. This was studied in the Scleroderma lung study 2, and it was compared directly to cyclophosphamide. And what we saw was that mycophenolate, given in tablet form, tended to be as effective as cyclophosphamide at improving lung function over 12 and 24 months. But the real benefit of mycophenolate was that it causes far fewer side effects than cyclophosphamide. And so nowadays, because we believe that mycophenolate helps both the lungs and the skin, this tends to be the first line treatment that is used for patients with scleroderma-associated interstitial lung disease. More recently, we've seen clinical trials with a drug called tocilizumab, or Actemra. This is a so-called monoclonal antibody, which is a drug that targets very specifically one part of the immune system, something called interleukin-6. And in so doing, it tends to avoid many of the side effects of the older immunosuppressants that act more broadly on the immune system. In the clinical trials that were performed with tocilizumab, it was given to patients with diffuse cutaneous systemic sclerosis who had evidence of active inflammation. So they either had joint pain and swelling, or they had evidence in their blood of inflammation. And when it was given to patients who met these criteria, the drug actually worked very well at preventing subsequent deterioration in lung function. And also when that was looked at using CT scans, there was a reduction in the development of interstitial lung disease. So increasingly for individuals with scleroderma who have evidence of active inflammation and interstitial lung disease, we will think about using tocilizumab. And then another similar drug is a drug called rituximab. So this is another monoclonal antibody, again, very specifically targeting one part of the immune system. In this case, it targets cells called B lymphocytes, and B lymphocytes are white blood cells that produce antibodies, and antibodies are the part of the immune system that is attacking the skin and the lungs in patients with scleroderma. And so myself and other colleagues, when I was in the UK, conducted a trial where we compared either rituximab to cyclophosphamide. And not actually just in patients with scleroderma, but in patients with other autoimmune diseases as well. And what we saw was that the rituximab was effective in the same way that cyclophosphamide was, both in the whole group of patients with the different forms of autoimmune disease, but also in patients with scleroderma, where we saw a benefit both for the lungs and also for the skin. And another group of investigators in Japan did a very similar study with very similar findings, that rituximab seems to benefit both the lungs and the skin in people living with scleroderma. And not only that, the rituximab causes far fewer side effects than cyclophosphamide. So increasingly, we tend to use rituximab for patients who show signs of getting worse on treatment with mycophenolate. And then there are some different forms of transplant that can be considered. So there is autologous stem cell transplant. This is essentially transplanting the bone marrow stem cells. This can be an effective treatment for patients with really bad scleroderma affecting multiple organs in the body. It's not a treatment we would use just for the lungs, but if a patient has really, really bad scleroderma affecting the lungs, the heart, the skin, then we might consider this as a treatment option. Similarly, if patients have really bad lung damage from their interstitial lung disease, then we will consider lung transplantation, although obviously the goal of the treatments that I've just discussed is to avoid reaching this situation. This is an example of an individual who's had a single lung transplant. So this here is the transplanted lung. On the other side is what has happened to their own native lung. And this is sort of 5 years after the lung transplant has been performed. We only perform lung transplant for severe disease because it is a difficult and complicated operation. And even after transplant, patients are at risk of chronic rejection. So the average survival after a lung transplant is about 5 to 6 years. So it can be an important treatment for end-stage lung disease, but it's a treatment that we avoid unless we really have to go down that route. And then more recently, we've seen the development of antifibrotic treatments. So I've already told you that the commonest disease that I see as a pulmonologist in my interstitial lung disease practice is idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is a condition that gets inexorably worse over time and tends to have an average survival of about 3 years. For the last 20 years, we've been trying to develop drugs that prevent the development and progression of fibrosis in this condition. Unfortunately, we have been successful. 10 years ago, we saw the development of 2 drugs, one called pirfenidone, one called nintedanib. And over the 10 years that we've been using those drugs, we've seen that the survival and life expectancy has improved by 2 or 3 years for people living with idiopathic pulmonary fibrosis. So having developed these antifibrotic drugs for patients living with IPF, the obvious next question was whether antifibrotic treatment might work for patients with other forms of interstitial lung disease, including scleroderma. And so we conducted this trial in patients with scleroderma-associated ILD. This was published about 6 years ago now. This was the so-called census trial, where patients were either treated with the antifibrotic drug nintedanib or placebo. And importantly, what we were able to show was that nintedanib slowed down the rate at which fibrosis got worse. And also, importantly, in that study, patients were allowed to be on mycophenolate. And so the individuals who actually did best over the course of the clinical trial were patients who were taking both nintedanib and mycophenolate, suggesting that the combination of an antifibrotic drug and an immunosuppressant drug might be the best way to prevent the worsening of scleroderma-associated interstitial lung disease. And then there's other important things we can do. So for individuals with more advanced disease, oxygen can be an important treatment. There haven't been specific studies of oxygen in patients with scleroderma ILD, but again, in idiopathic pulmonary fibrosis, we know that the use of oxygen can certainly improve quality of life for individuals with fibrotic lung disease. Similarly, in patients with idiopathic pulmonary fibrosis, we know that exercise can improve symptoms, it can improve exercise capacity. And so again, for all forms of pulmonary fibrosis, we'll now tend to recommend something called pulmonary rehabilitation, which is a structured program of exercise conducted with a respiratory therapist. Although it doesn't change the underlying disease, it generally is a very effective way of helping people live much more effectively with their condition. There's also an important role for trying to prevent infection. So we tend to strongly recommend the use of vaccinations, particularly the pneumonia vaccine, the pneumococcal vaccine, which we tend to recommend every 5 years, the flu vaccine every year. People should have had the COVID vaccine and the relevant boosters. And there's also a new RSV vaccine that became available last year, which again, we're recommending for all of our patients with interstitial lung disease. Should patients develop respiratory infections or flu or COVID, we also recommend early treatment. So if you have any symptoms of chest infection, then you should be contacting either your primary care doctor, your rheumatologist, or your pulmonologist. And then there's other things that we can do to help people live with their condition, to manage symptoms. We can provide support with activities of daily living, For people who need oxygen, we can help to get payment of electricity bills with your electricity company. We can just treat symptoms directly. So there are drugs that we can use to manage symptoms like breathlessness and cough. We like to, in our clinic, also provide support for carers, because we know that living with someone with breathlessness often puts a big burden on spouses or children. And so we try and provide a lot of support with that. And of course, for patients with very severe disease, we also see an important role for end-of-life planning. And as I've said, there are lots of guidelines now. There are 3 different sets of guidelines for treating systemic sclerosis and associated interstitial lung disease. I'm not going to go into those in detail, but certainly your rheumatologist and your pulmonologist should be aware of those treatment guidelines, because it will help select the best therapy for individual patients. And then very quickly, just for the last few minutes, I thought I would cover off the important place of clinical trials in managing scleroderma ILD. So we have seen big developments in the way that we treat scleroderma and the associated interstitial lung disease over the last decade, but we certainly haven't conquered the problem, and we certainly haven't got to a point where we can cure or reverse interstitial lung disease. And so it's really important that we continue with clinical trials to find better, more effective drugs with fewer side effects. And so the way the clinical trial process works is that there's a lot of work that's done in laboratories to identify potential treatments, where experiments are done on cells or even mice. And once an effective treatment or a potentially effective treatment is identified, it then goes into clinical trials into human beings. And so there are different phases of clinical trials. There's phase 1, which is the first time a drug is given to human beings. And that tends to be conducted with healthy volunteers. And the reason for those studies is to make sure that drugs don't have unexpected or severe side effects when given to humans. So that tends to be a healthy volunteer study. The first time that drugs are given to patients tend to be phase 2 trials. These phase 2 trials tend to be relatively small, so they have fairly few people as part of them, and they also tend to be relatively short, so they'll run for somewhere between 1 to 3 months. And the goal of these studies is to make sure that the drug is safe in patients with the disease of interest, but it's also the first time that an effort is made to see if the drug actually behaves in the way that is expected. That is to say that it has an impact on the interstitial lung disease in people with scleroderma. If those trials are positive, we then move on to phase 3 studies. And in phase 3 studies, what we're doing is confirming over a longer period of time that the drug is safe and effective. And these studies are very carefully looked at by the FDA and other regulatory bodies in different countries, and are used to decide whether a drug should go into clinical practice. And then finally, we do phase 4 studies, which is once a drug is approved for clinical practice, we may do extra trials to try and understand whether there are specific patients who really benefit from treatment. Now, what are the pros and the cons of clinical trials? Well, clinical trials are obviously very important for us to be able to develop new treatments, but not every patient is going to want to go into a clinical trial. And there are some downsides to clinical trial participation. First off, in most cases, we use a placebo. A placebo is a mock drug, so a sugar pill or a saline injection or something like that, a medication that we know has no effect. And the reason that we have placebos is because even just putting patients into trials often seems to be beneficial, because they get close monitoring of their disease, they get early treatment of any complications, and so people in trials tend to do better than people who aren't. So we need the placebo to be able to compare the active treatment. And there are certainly times when we've done placebo-controlled trials and we've been horrified to find that treatments that we've used for many years actually don't work in the way that they should. So placebo is very important, but it does mean a proportion of people in trials aren't going to go on the active drug. The other downside of being in trials is the frequency with which patients have to come to the center. So this is an example of a clinical trial that we did in people with idiopathic pulmonary fibrosis. Each vertical line is an example of when patients had to come and visit the clinic. So they had to come at the start, and then every 2 weeks, and then every 4 weeks. So they had to come to the hospital lots of times over the course of a year. So there is a time commitment to being in trials. But on the plus side, there is this opportunity to get access to treatments before they're available in general clinical practice. And not only that, there's often then the opportunity to go on open label treatment once the study has completed. So if the trial is effective, then everybody tends to be offered the treatment before it is available and approved for use in clinical practice. And so all of this then leads on to the Conquest study, which is a study that has been developed by the SRF that is designed to accelerate the development of new treatments for people living with scleroderma-associated ILD. This has been a massive undertaking by the SRF. Greg, as the medical director, has been putting in a huge amount of effort to doing this. There are 130 or more than 130 hospitals worldwide that are participating across many, many different countries. We are hoping to recruit, several hundred patients, and we're also hoping that the way this trial is designed is not just to look at a single treatment, but actually to look at multiple treatments. So this is something called a platform trial, which differs from normal studies. So in a normal trial, what happens is we look at a single treatment, and then at the end of the trial, everything shuts down, and we stop work on it. In a platform trial, what happens is that we take multiple treatments and we can put them into the clinical trial. So we can look at the first treatment, and then a second treatment, and then a third and a fourth and a fifth. And that means that we benefit from the trial continuing to run over time. We don't have to stop and start, which takes a lot of time and effort. And not only that, we can compare multiple drugs at the same time, which means that the number of people on placebo can be kept to a bare minimum. It means that most people in the trial are going to be on an active drug, and only a small number will be on placebo. And by using all of these advantages, we're hoping that we can really accelerate the development of new treatments for scleroderma-associated ILD. And if people on the call want to go and find out more information, there is a lot of detail on the SRF website. So you can see the website at the top, srfcured.org/research/conquest, or you could just put Conquest trial into Google and I think it'll come up. And if you go to the website, you'll be able to find out where the clinical trial sites are around the world. And you'll also be able to find more information about getting involved with the trial if that's something that you would like to do. So, apologies that I've run a bit over, what with my internet problems, but just to wrap things up, ILD is an important problem in scleroderma, and hopefully you now all have a slightly clearer understanding of what interstitial lung disease is and how it impacts the lungs. As I've told you, the best way to diagnose interstitial lung disease is with a CT scan. And then once it's been identified, the best way to monitor it is with lung function testing. Thankfully, we do have a number of treatment options that we know are effective. But it's also important that we work on developing better treatments going forward. So Greg, I'll hand over to you to lead this session.
Great. Thank you very much, Toby. So why don't we jump right in? We've gotten a long list of questions, which I really appreciate. And I think I'm going to kind of try and batch them into basic concepts. So why don't we start with the new diagnosis? So, as you said, someone who you're seeing for the first time, you're going to do a CAT scan to really look at their lungs. Let's say that patient does not have any lung involvement at that moment. How are you going to manage that patient? Do you have a point where you're going to repeat the CAT scan, or is it all through lung function testing? What does that look like?
Yeah, so I think if someone has had a normal CT scan, it doesn't completely rule out the possibility that they could that they could develop interstitial lung disease in the future, particularly if they've been recently diagnosed with scleroderma. So really, the 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 main time period during which people develop the interstitial lung disease is really during the first 2 or 3 years after the skin disease develops. So that's really the period of time where we have to be careful in monitoring. So if somebody has a normal CT, then there's certainly a much smaller chance that they'll ever develop ILD, but it's not quite a zero chance. In that circumstance, I would continue to monitor people once a year with lung function testing. I would also do clinical examination. So the one thing I didn't say in my talk is that when you listen to the lungs of people with interstitial lung disease, you can often hear a very characteristic crackling sound. And so as a pulmonologist, I will listen to my patient's lungs at every visit. And if I was to hear the development of that crackling, it would be a trigger for doing a CT scan, as would a change in the lung function. So I wouldn't automatically repeat a CT scan, but if somebody who'd had a normal CT scan had symptoms, either had crackles at the bottom of their lung or had a change in their lung function, then I would think about repeating the CT.
Great, thank you. And for that patient, again, this patient who the CT looks okay, is there something that patient should be doing? Is there anything they can do that lowers their risk of eventually developing lung involvement?
So I think the honest answer is we don't know. But my broad answer to that is sort of do everything you can to look after your lungs, which means not smoking, not living in a household with people who smoke, so avoiding smoky situations. Also taking the general precautions about trying to avoid infection, particularly viral infections. So I think all patients with scleroderma should have the vaccinations that I mentioned, not just patients with ILD. And there may also be a beneficial role for exercise. You know, the general advice that all of us get about keeping ourselves as healthy as we can, I think trying to take regular exercise where for 20 or 30 minutes a day, 5 days a week, you're going for a walk or a cycle ride or a swim, just something that, you know, gets you breathing a bit harder. So I think those three things are the things that we should be doing, all of us, to look after our lungs.
Great. Okay, great. Thank you. And you mentioned sort of the timeline that sort of the first couple of years after skin involvement are the highest risk. And then over time, the risk goes down, although it never completely goes away, of eventually developing lung involvement. We have had some questions around the different types of scleroderma. And what I mean by that, in my mind, bucketing into people who only have skin involvement, those with diffuse cutaneous, where you have both skin and systemic, and those with limited, who really have very little skin involvement but have systemic involvement. Is the risk different for those groups? Does the risk exist for all three groups of lung involvement?
Yeah, I mean, certainly when you look at it at the population level, the risk is different. So patients with diffuse cutaneous systemic sclerosis have the highest risk. So about 80% of people with diffuse disease will have ILD. By contrast, with limited disease, it's about 40 to 50% will have ILD. But 40 to 50% is still a pretty high risk. And so I would still treat all patients the same way when it comes to screening for ILD. I wouldn't use the extent of skin disease as a criterion to decide whether to screen or not, because there is still a 50-50 chance that someone with limited disease will have interstitial lung disease. So it's still important to identify it at an early stage so that we can seek to prevent subsequent progression. So yes, there are differences, but I don't think that should ultimately influence how we sort of monitor the lungs.
Okay, that absolutely makes sense. Thank you. So why don't we take the other potential situation where you have a new patient who comes in, you do the CAT scan, and you do see evidence of early lung involvement of ILD. Tell me a little about that patient. How obviously they do a workup, but how are you going to monitor that patient? Is that patient going to get repeated CAT scans, or are you just monitoring through the pulmonary function?
Yeah, so certainly my preferred way is monitoring through lung function. So if we know someone has interstitial lung disease, then for the first year or two after identifying it, I will see them every 3 or 4 months and do lung function very regularly. And the reason for that is we want to get a clear understanding of how their lung disease is behaving. Once we've sort of followed people for that first couple of years and we have an understanding of how things are, if things are relatively stable on treatment, then often we will move to sort of 6 monthly monitoring. And you know, patients who've lived with scleroderma for a decade or more, where we've seen, you know, true stability over time, sometimes we only follow up once a year. But it's really about tailoring the follow-up periods to our concern that the disease might change. So very early on, we want frequent monitoring, but often with time, that can be stretched out to much more infrequent visits. And, you know, obviously, in that circumstance, patients are likely to have both a rheumatologist and a pulmonologist. And so I will work with my rheumatology colleagues so that we are, you know, coordinating follow-up so that patients aren't, you know, seeing their rheumatologist every 3 months and their pulmonologist every 3 months and having to make 8 trips to the hospital every year. We will try and coordinate so that some of that lung function testing can be done at time of rheumatology appointments, for instance.
Hey, thank you. Thank you. That makes sense. So the other large bucket, looking through the questions we're receiving, is around treatment. So obviously, treatment is very individualized, and you know it is really very patient dependent. With that said, any thoughts you can share about sort of a general approach when you have a newly diagnosed patient, sort of where you start and how you decide what medications you're going to start with?
Yeah, so obviously in this talk, I have focused primarily on the interstitial lung disease, but obviously when we're thinking about treatment, we're going to be thinking about a patient holistically, and we're going to be thinking about their scleroderma as a whole, not just how it affects the lungs. And so there will be some overlap between how we think about treating the skin disease and how we think about treating the lung disease. As I alluded to, I think mycophenolate tends to be the first line treatment for the vast majority of patients, particularly patients with diffuse cutaneous disease, where we're trying to prevent worsening of their skin disease at the same time. And so it is, you know, it is likely that we will try and kill 2 birds with 1 stone, that we will use mycophenolate both to try and manage the skin and also to manage the lungs. If, however, despite the mycophenolate, patients are still developing worsening complications of their disease, whether that's the interstitial lung disease getting worse or whether it's the skin disease getting worse, then we will think about some of these other treatment options. And again, as I alluded to in my talk, there's a sort of specific subset of people for whom Actemra, the anti-IL-6 antibody, looks to be particularly effective, and that maybe accounts for about 10% of people with scleroderma. So if people have active inflammation, they've got joint pain, they've got elevation of their inflammatory markers on the blood testing, they've got diffuse cutaneous disease and ILD, then Actemra is potentially a very good treatment for them. For the remainder of patients, if we're worried that the scleroderma itself is still active, if there's activity of the skin disease and the lung disease, then we would tend to think about the use of rituximab. But if the skin disease is well controlled and it's just the lung disease that seems to be getting worse, then we would think about using an antifibrotic drug. So in that circumstance, nintedanib which is targeting the lung disease, but really has no effect on the skin disease or any of the other sort of components of scleroderma, would be a good choice if we're treating the ILD alone.
Great, thank you, thank you. And I think that answer really comes back to what we said earlier, that the treatment really is very individualized and really depends specifically on the symptoms of that patient. With mycophenolate being the first line, often I'm getting a number of questions around side effects of mycophenolate, particularly GI side effects. Is that something you see a lot that's very limiting for patients?
So it is often dose dependent. It's fair to say that in the clinical trial, the SLS1, they used a very high dose of mycophenolate. So they use 1.5 grams twice a day. At that dose, about 1 in 5 people will get appreciable gastrointestinal upset, whether it's nausea, bloating, or diarrhea. I think certainly in my practice, and I think many rheumatologists will go for a slightly lower dose. They'll go for 1,000 twice a day. And at that dose, many more people tolerate it without side effects. In my experience, 9 out of 10 people can take that dose without major problems. For people who are in that 1 in 10 that still get GI side effects on that lower dose, there are some alternative options. One is we can go even lower with the mycophenolate, but the concern about that is that we might not be getting the full treatment benefit. There are some different formulations of mycophenolate. So the one that we typically use is MMF, like Mofetil, but there's a variation called mycophenolic acid, which once it gets into the bloodstream, works in exactly the same way. But some people find that is slightly easier to tolerate. So often the first step would be to switch people to mycophenolic acid. If that really doesn't work, then there are immunosuppressant alternatives that we think work in a similar way to mycophenolate, so either methotrexate or azathioprine. So often we will try those. And if that really doesn't work, then one of the options would be to switch to something like rituximab, which doesn't tend to have any GI side effects associated with it. So there are ways to try and work around the side effects if that is a problem that patients have. But I certainly think starting at a lower dose rather than going for the very high dose that was used in the clinical trials is probably the best option to begin with.
Great. Thank you. So we're almost out of time. I think let me ask you one final question before we wrap up, which is, can you give us your thoughts of the future of treatment? What's out there? Is there anything you see as particularly promising that may be coming down the pike?
Yeah, and obviously I have a bias because we're all involved in the Conquest trial. But one of the drugs that's in the Conquest trial, nerandomilast, has been shown to be effective in idiopathic pulmonary fibrosis. So I think we've all got very high hopes that it'll be effective for patients with scleroderma ILD. Where I would like to get to over the next decade is that we're working much harder to prevent the development of interstitial lung disease. At the moment, we're sort of shutting the stable door after the horse has bolted. We're sort of trying to prevent worsening of interstitial lung disease that is there. But I think for the future, we really should be working at prevention so that we stop patients ever getting to the point where they need oxygen or anything like that. So that's where I would like to see us heading in the next decade, is prevention rather than just treatment.
Great. Okay, thank you very much. Well, that really brings us to a close for today's program. So Dr. Maher, thank you very much for sharing your time and your expertise with us, all of us. And for the audience, before we close, we'd really love to hear your thoughts. You're going to receive an email with a link for a survey, and that feedback is really very valuable for us. It helps us design our future programs, our future topics, to make sure we're really providing the content that matters the most to you. So please enter the survey. And if you do enter the survey, there is a chance to win a prize. So once again, thank you everyone for joining us, and we look forward to doing more of this in the future.